Dr. I'm Dr. Mbapita, so I'll be taking practice question 9. Okay, as the CMD of a hospital, you met series of problems at the pharmacy unit of the hospital. Up to 8 problems were mentioned: expired medications, supplies are not paid on time, drugs needed in the theater, and emergency not available. Question A, what will you do as the chief medical director? B, name the hospital committee concerned with drug prescribing, formulary, and procurement. C, what are the functions of the committee? D, what are essential drugs? And E, list 5 characteristics of essential drugs. So to the first question, what will I do as the chief medical director? So as the chief medical director of the hospital in question, based on some of the problems they mentioned, I want to have an urgent meeting with the head of the pharmacy, okay, and address some of those problems as itemized. Looking at expired medications, I want to conduct an audit of all the medications in the pharmacy, especially the expired medications, to help me find out why those drugs expired. Could it be cost? Maybe the drugs are quite expensive. Could the insurance play a role? Are there substitutes? Maybe patients can't really afford it due to the poor economic situation. The quantities of the drugs purchased, are they maybe quite, maybe are they much, maybe plenty of the drugs were purchased? Are the doctors even aware, the doctors prescribing medications at the clinic, are they aware that such drugs are even in the pharmacy? So sensitization is also very important. And also to also buy drugs that have a longer expiry date. So this is what one of the ways these are the ways I'll probably look at expired medications. Okay, so the second problem, suppliers not paying on time. Okay, this is also very, very important. There are a lot of bottlenecks in the hospital. Whenever money is released for something, maybe it's either the person that delivers the letter, maybe, whenever money is being released, there are a lot of bottlenecks, like I said, maybe from signing letters to letters being kept in someone's table, not being transmitted to the next table. So at times, the communication is always an issue. At times, funds are allocated, but before it gets to the particular department, it might take 2-3 weeks. So some of these bottlenecks have to be looked into and has to be addressed very, very, very well. Okay, so also emergency drugs are very, very important. I have to prioritize critical drugs needed for the theater and the emergency units. Implement emergency procurement procedures to quickly acquire necessary medications when they run out of stock. So besides some of these problems that we captured in the recall, other things I want to do as the chief medical director is to ensure communication and coordination. It's very, very important between the pharmacy department, the medical staff, the administrative team. There has to be a form of communication, because without communication, a system is bound to fail. Okay, I also want to look at quality assurance and compliance. Regular audits have to be done, maybe every 2, 3, or quarterly. Audits is also very, very important. This question also brings in the aspect of clinical governance, that you always have to a health system that without an audit, whether it's quarterly or maybe 3 monthly, anyone, it's very important that it helps to preserve the quality assurance and compliance of certain protocols that have been established in the hospital. Also, staff training and development is very important. You have to find a way to always train the staffs with the recent things, innovations, develop programs to keep them up to date with the current situation of things. Also, how to manage skills in inventory management, customer service, and adherence to protocol. Because, for example, you might say you've trained them on something maybe in January, and maybe you don't really have a schedule to keep retraining them. At times people tend to deviate away from the norm. Okay, also technology integration is also very, very important. Now we are having a lot of EML. Hospitals now are moving away from folder to EML. So it's also very, very, very important. Okay, so technology integration is also important. And also I want to prioritize patient safety, ensuring that the medications available are properly stored and administered according to protocol. So by systematically addressing these issues and implementing these strategies, I can work towards improving the overall effectiveness and efficiency of the pharmacy unit within the hospital. So to the committee concerned with drug prescribing, formulary, and procurement, okay, the name of the committee is the Pharmacy and Therapeutics Committee, P&T Committee. So what are the functions of this committee? The number one function of this committee is drug formulary and management. So what do I actually mean by drug formulary management? Simply means simply means it's a list of drugs preferred by a health institution to ensure cost-effective treatment options for your patients. So this is one of their key functions. Okay, also they are also part of the drug prescribing. They also establish prescribing policies. It's also their duty to ensure that prescribing policies align with evidence-based medicine, safety protocols, and cost-effectiveness considerations. Also, medication safety and efficacy. This committee reviews and evaluates medications based on their safety, efficacy, and potential for interactions. They make recommendations regarding the inclusion, exclusion, and restriction of medications in the formulary to optimize patient outcomes. Also, therapeutic guidelines. They develop and update therapeutic guidelines for various medical conditions to guide healthcare providers in the selection and use of medications. Okay, other functions like are here the medication use evaluation, also procurement and budgeting. Also, it's also very important for the committee to ensure that medications are acquired at a competitive prices without compromising quality. They also contribute to budget planning related to pharmaceuticals. Also, education and training. The committee provides education and training to healthcare providers on drug utilization, new medications, formulary updates, and prescribing guidelines. And very, very important is the adverse drug reaction monitoring. They oversee monitoring and reporting of adverse drug reactions within the hospital, taking necessary actions to mitigate risk associated with medication use. So overall, the pharmacy and therapeutics units play a crucial role in promoting safe, effective, and cost-efficient medication use within the hospital setting, ultimately aiming to improve patient care and outcomes. So what are essential drugs? Essential drugs, according to WHO, are medications that satisfy the priority healthcare needs of the population. These drugs are selected based on the efficacy, safety, and cost effectiveness. So they said list 5 characteristics of essential drugs. Okay, one is efficacy. Essential drugs have to be proven to be effective in treating a certain condition. They have to be safe. They have to have a safety profile, minimizing risk of adverse effects to patients when used. Quality. Essential drugs are manufactured according to quality standards to ensure consistency and reliability. They also have to be affordable. These medications are the prices, cost effectiveness is also very, very important because it's not just about having these drugs. Can patients afford it? So they have to be affordable as much as possible. Accessibility, they should be readily available within healthcare facilities and communities when they are needed. So as a way of recap, the WHO maintains a model list of essential medicines which serve as a guide for countries to develop their own national list of essential drugs tailored to their specific healthcare needs and priorities. Okay, so these are some of the examples of essential medications, which runs from antibiotics to antimalarials to antiretrovirals, analgesics, antibiotics, antidiabetics, vaccines, anti-tuberculosis medications, and drugs for mental health. So these examples represent a fraction of the medications typically included in the national list of medicines. The selection of essential medicines may vary based on local disease prevalence, treatment guidelines, and the availability of healthcare resources. The goal is to ensure that these medications are accessible, affordable, and used appropriately to improve public health outcomes. Thank you.
Thank you so much, Dr. Ba, for that beautiful presentation. You are right on. In fact, you kept to time. Thank you so much for the beautiful presentation. Okay, so now we'll take comments, questions from the participants first of all, and then please keep the thanks coming on the chat. Okay, so Dr. Forrest is saying thanks for that beautiful presentation. I don't see any hands up yet. Okay, okay, let me ask my own question while I'm waiting for others. Okay, just please go back to the question. Okay, so I was just thinking aloud. That first question, say, what will you do as a CMD? I was thinking if if it will be okay to set up a committee to actually address the issues and make sure that they are solved. That's one. And then the other committee you mentioned, the pharmacy and therapeutics committee. Would I be right to say that, okay, that's the committee that is supposed to handle the issue with you as a CMD? And then my third question is, who are the members of the committee? Okay, thank you. Okay, so a lot of thanks on the chat. Go ahead.
Okay, so very important. So it's actually the committee that will be in charge of looking at some of the problems that have been mentioned earlier. So the P&T committee, they consist not just of pharmacists, even physicians, nurses, administrators, risk managers, and quality improvement managers. Very, very important. So these are some of the members of the committee.
All right, thank you so much. So we have a lot of thanks on the chats. Let me just take some of them. Dr. Blessing Azukoye, Dr. Yahya Mohammed says a very good one. Dr. Abimbola, Dr. Becky Obasi, thank you. Dr. Rita Lako saying thank you. Dr. Momodu saying thanks so much. Dr. Raleigh, thank you for the beautiful presentation. Dr. Makri, Dr. Regina Wiki, Dr. Jamila Bashir, Dr. Adiboka saying thank you for the excellent presentation. Dr. Christian Ade says thanks, Doc. Great presentation. Dr. Bimpe says thanks for the lucid presentation. Dr. Justice Ibiti, Dr. Ifoma says thank you, Your Excellency. Dr. Christian Ade says, well, will you do this yourself or you need a committee to assist you? Okay, Dr. Christian, I think I already asked your question. Okay, maybe later others can throw more light on it. Dr. Pute says, thank you for the detailed presentation, Peter. Then Dr. Ifoma is adding nurses, pharmacists, other healthcare workers will make up the committee. Dr. Korafo says, thank you for the presentation. Dr. Itoha, thank you for the presentation. Okay, my questions have been asked by Dr. Ikele. Yeah, I think I was speaking a lot of people's minds. Okay, Dr. Rita says, thank you. Dr. Mustafa says, thank you. Dr. Bashir. Dan Sander says, thanks. It's epic and succinct. And then Dr. Salim Ahmed says, thank you for the lucid presentation. Let me check if I have any electronic hands up. No hands up. Okay, so if there are no more comments and questions, Ma, please, I'll hand over to you.
Okay, thank you, Dr. Peter. Thank you, Dr. Ekele. It was a fair attempt, really. You did well. Thank you so much, Dr. Peter. You did wonderfully well. For the first question, indeed, you need a committee. That's why we tell participants that you feel that you have time now, don't worry. The CM is waiting for you to become a consultant, to put you in at least 2 committees. Before you ask, you just get your paper and they appoint you before you can say, my name is this. You're already in like 2 committees already. Committees ready to do this, the CMD is ready to do this themselves. They just call you and make you head of a committee and you go and sort it out and report back to them. So this number 1 question, a committee actually will be formed and the head of the pharmacy committee will be in charge. Then a member of the admin, maybe DCMAC or CMAC or someone, one of them will report back to the CMD. So it's not directly CMD. I think they have time. You don't have time on that. They are quite busy. So that's why most times just allocate some of these responsibilities to committees and ask them to get back to them on their findings and their summaries and the way forward. So members of the committee, the person in charge of the pharmacy, the nurses and major heads of the department, all of them will be in charge. And procurement person in charge of procurement will also be among the be in the committee. Everybody that has 1 or 2 things to do with drugs, they will be in the committee. So I think that's what it. What's that first question again, Dr. Oba?
Okay. What will I do as the chief medical director?
Okay. So that's what you do. So what you say, you just say I'll form a committee, I relax now. You talk about the committees, you talk about the members of the committee and what they are, and definitely there'll be a secretary, somebody that will be taking notes. So you talk about list the people that should be in the committee and their various responsibilities, so that they will know that you are thinking. You don't just I'll form a committee and rest. No, you form a committee, you list out people that should be in that committee, different people that should be, like I said, all major heads of the department, major stakeholders, a representative of the administrative arms of the hospital, CMAC or the DCMAC or one of those top admin staff will be there. The procurement officer, the chief the pharmaceutical issue, the pharmacy department, issue the nursing care, and then each of the department, internal medicine, surgery, O&G, pediatrics, they all will be involved. Procurement officer, then a secretary that will take notes of, then the financial person in charge of the finances, the accountant of the hospital, then a lawyer, all of them. The hospital lawyer will be there, the hospital accountant will be there. So these are the people that will make up the committees. So they will discuss all the way forward, why this happening, why that's happening. Then once they're done, they take the findings too. The person in charge, the admin staff take these findings. Also part of the admin take these findings to the CND, and they work on the deficiencies and put checks and balances on other issues. Dr. Kopi, Dr. Fatima, Chief Remigos, I don't know, and Chief Cookie, don't know if there's anything we need to add to this number one question.
We'll talk at the end.
Okay, yes. That's fine. Dr. Remigos, sir, any comment? Chief Cookie, any comment?
Yeah, good morning, everyone.
Morning,
Thank you. So I think if I'm going to answer this question, I mean, what they are looking out for is to say you carry out a clinical audit, because that's actually what would encompass all these things you are mentioning. Because it's with the clinical audit that you are going to assess what is going on ground, compare it to the standard process, and then find out about your shortfalls, and then provide solutions, carry out the solutions that you found out, and then give a time frame where you are going to come back to assess your progress. And then, of course, re-audit if you are not yet there. So that's actually what is apt in I think that would be the main thing they are asking for, that you will do as a CMD, is to conduct a clinical audit. So the clinical audit, you are either going to be looking at the structure, the process, or the outcome. And I think with all these issues, the expired drugs, suppliers not being paid on time, drugs needed in the theater and emergency are not available, I think it has to do with the structure. So that's actually what you are going to be looking at. And the manpower, the money, and all that is involved. So you would set up your committee. So I think Dr. Christabel did a good job by mentioning all the members of the committee. So the members of the committee, you are going to look at those who are directly involved in interfacing with this with the processes, and then of course those who are in authority to effect the changes, and then those who are going to give all what is needed for the clinical audit to be carried out. And then you would have a meeting where, of course, you are going to prepare and plan, and each clinical audit has to have a title and objective, because your objectives are going to be SMART. So it's specific. Why are these issues coming up? Then you need to, it's going to be measurable, achievable, realistic and then it's time bound. So you give yourself time for when you are going to gather all this. Then you look at the standard process, because now you're looking at the essential drug list. So a hospital such as yours or a bigger tertiary hospital, what are they doing that they are able to achieve all this? So you'll find out from them, get their protocol, and then you frame up a questionnaire, which is now going to show the knowledge and pick up the issues on ground. And that way you would know, you are now going to measure your performance and know what you are doing. And then next thing is to go out now and then, of course, apply what you found out are your shortfalls. And at the end of the day, you give a time for you, and then you would, of course, submit your recommendation to the chief medical director that these are the things, the reasons that the hospital doesn't have an effective essential drug list. Because one other thing too, either members of the hospital don't even know that these drugs are available. Because over time, like even in my hospital, they usually remind the pharmacy department reaches out to us to tell us that these drugs are available. These drugs, they have short-dated drugs, that so that doctors will know to prescribe these medications so that they don't expire on them. So these are the things that the pharmacy department is going to be involved in, and after which you will give a time to now re-audit and see that your practices have now improved to prevent all these myriad of issues reoccurring. So I think I'll stop here. Thanks.
Oh, thank you, ma. Thank you so much, ma. Give me a very wonderful perspective. Thank you. I think we've done justice. And no more comment. Thank you so much, our facilitators, for elaborating on this particular question. Dr. Ekel, I think there were no more that other questions were not raised, have not been answered. Have all the questions been answered?
Yes, ma'am.
Okay, that's fine. So move to the second presenter.
you.
Dr. Oba, once again, thank you.
Okay.
Thank you.
Thank you so much, Dr. Mba. Dr. Salim. Dr. Mba, you can unshare your slide.
Okay, thank you, ma. Let me try sharing the slide.
Dr. Salim, okay. Okay, go ahead, please.
Okay. Is my slide visible?
No, sir.
Okay. Maybe Dr. Amin Bashir, can you please assist me in sharing the slides? Dr. Amin?
Okay, is Dr. Amin here?
Dr. Bashir Amin.
Okay.
He's in class. But Dr. Salim, have you
yes.
posted it on the blog? Or have you sent it to him privately?
Yes, I've sent it to him personally.
Okay.
Or if I could just send it to the blog for anybody to help me share.
Send it to the blog so that someone else can help share in case he's having challenges.
Okay, thank you.
Still attempting to share because I'm also trying to share here. It's not allowing me.
Anyone can share, Dr. Aminu. Our dear, what's it again?
facilitators, consultant, senior colleagues and colleagues, I will begin by apologizing to you for the technical glitches. I'll be presenting practice question number 10 from November 2023 national examination, which is a clinical scenario of a banker, non-hypertensive and type 2 DM with a height of about 200 centimeters, weight 180 kg, that presented with sudden onset of pain on his right big toe and ankle. Symptoms usually was after going to party with friends. He was on medications including hydrochlorothiazide and aspirin. So the questions were, what is the most likely diagnosis? Mention 3 differential diagnoses. What is the most important investigation? Which drug will you stop? Mention 3 drugs for acute treatment of this condition. Mention 2 classes of drugs for chronic phase. What are the other comorbidities / risk factors associated with this condition? So the answers are as follows. The most likely diagnosis would be acute flare of gout on the background of metabolic syndrome, considering the fact that the patient presented with acute onset of pain, even though they said that the pain is recurrent and usually occurs after going to party with his friends, likely following an alcoholic binge or excessive eating. And he also has background type 2 DM hypertension. And if you measure his BMI, it will be somewhere around 45 kilogram per meter square. So my differential diagnosis will include cellulitis, septic arthritis, and rheumatoid arthritis. The next question is the most important investigation to do in this case is synovial fluid analysis, which is the gold standard. Other auxiliary investigations that one could do include the serum uric acid level, though it's not always might not always be elevated in cases of acute flare of gout, which we'll see later during the course of the presentation. The drugs that I'll be stopping as a result of this acute flare of gout will be hydrochlorothiazide, as this has been incriminated. Aspirin also in low doses has been incriminated as a cause of a flare of gout. So although in the question, the dosage of the aspirin was not stated, but it will also be wise to stop this medication as well. The drugs for acute flare of this acute flare of gout include non-steroidal anti-inflammatory drugs like ibuprofen, diclofenac, or naproxen, or oral glucocorticoids. Glucocorticoids can also be given orally, intramuscularly, or intra-articularly. You can also use oral colchicine during acute flare. The classes of drugs for chronic phase include xanthine oxidase inhibitors like allopurinol. If there are no contraindications to it, you can also use febuxostat in those patients that tend to have a moderate to severe degree of renal impairment. Other class of drug that could be used include uricosuric like probenecid. The associated comorbidities or risk factors, which is the last question from the slide, include obesity, which our index patient has, diabetes, hypertension, psoriasis, osteoarthritis. Drugs like cyclosporine, thiazides, levodopa, ethambutol, parazinamide have also been incriminated in this acute flare of gout. So I will now be taking a quick overview of this acute gout using the following outline. Introduction, epidemiology, pathogenesis. By way of introduction, metabolic and crystal arthritis are categories of joint diseases characterized by inflammation, which are linked to specific metabolic abnormalities and or crystal deposit. Example of this include gout and calcium pyrophosphate deposition. Clinically, these conditions usually manifest as an acute episode of joint pain, swelling, and stiffness. Next slide, please. Gout as a disease entity can be defined as a metabolic disease that most often affects middle-aged to elderly men and postmenopausal women. Usually results from an increase from body pool of urate with hyperuricemia, 6.5 milligram per deciliter in males, while 6 milligram per deciliter in female. Typically, it is characterized by episodic, acute, and chronic arthritis, which is usually caused by the deposition of monosodium urate crystals in joints and connective tissue tophi, and the risk for deposition in kidney interstitium causing acid nephrolithiasis. Next slide, please. The prevalence of this disease condition has increased markedly over the time, largely because of the change in eating habits and because of the increased usage of drugs like hydrochlorothiazide and increased incidence of metabolic syndrome ranging from hypertension, diabetes, and dyslipidemias. So the prevalence may vary with age. The peak incidence is usually between 4 to 6 decades in males and 6 to 8 decades in female, and it might range from country to country. The prevalence of hyperuricemia generally ranges between 2.0 to 13.2. As I've stated earlier, it's not every patient that has hyperuricemia that come out with gout. Generally speaking, about 10 to 20% of individuals might have hyperuricemia without necessarily presenting with the disease condition. On the other hand, about 10% of this population might present with acute flare of gout and having a normal uric acid level at the time of presentation. In a study done by Adelo et al., he found the prevalence of this disease to be 6.2% in subjects attending rheumatology clinic in Lagos, and it was found to be associated with obesity, diabetes, osteoarthritis, alcohol consumption to a lesser extent. A similar study conducted in Zaria revealed that the prevalence was about 9.2%. Now, coming to pathophysiology of this disease condition, it involves a series of complex and interacting processes. Hyperuricemia can result from either an increased production or decreased excretion or combination of the two processes as well. Generally speaking, it's more of in 90% of the cases, it's the reduced excretion that is responsible for this condition. So I will now use this schema to try to explain some of the pathophysiological condition that I've explained earlier. So usually you can have elevated purine source either from catabolism of purine or from thymolysis syndrome or increased intake like beef, beer, or overload of this shell food. Or you can have on the background of the risk factors like male gender, like we stated earlier, is a risk factor because the hyperuricemia usually starts the increase in uric acid level increases in male during puberty, while in those female, it's usually after menopause that starts. Then the age, obesity, and ethnicity also play important role factors. So if there's an increase in this purine, the products of purine metabolism, this will eventually lead to production of xanthine, and finally will have hyperuricemia. So usually it's been excreted through the renal clearance. About 90% of it is excreted. In an event, a patient is having some renal impairment, or there are some drugs that will interfere with the excretion of these drugs, such as hydrochlorothiazide, aspirin, will hamper with the movement of the uric acid out of this, leading to deposition of this monosodium urate in the bones and other soft tissues. Next slide, please. So this slide depicts some of the rare monogenic causes of gout. The first one is phosphorybasyl pyrophosphate synthase of overactivity, or hypoxanthine phosphorybasyl reductase deficiency. Other conditions like glucose phosphate deficiency, fructose 1P aldolase deficiency can also result in development of gout later in life. These are the medical comorbidities or associated risk factors that have been associated with the development of gout. They include obesity, hypertension, chronic kidney disease, diabetes, psoriasis, other lymphoproliferative disorders, hypothyroidism, chronic obstructive pulmonary disease, hypoparathyroidism has also been incriminated. The clinical features or the clinical spectrum of this disease has been described as a chronic disease characterized by 4 distinct stages. And under these stages, we have the asymptomatic hyperuricemia, in which a patient might have elevated serum uric acid level without necessarily manifesting with the symptoms. In this case, many at times, you can see a patient that has this thing, like I've said earlier, about 10% of the population might have elevated hyperuricemia without necessarily presenting with the symptoms of gout. The second stage will be the acute gout attacks, which index patient presented with. In this patient, the patient will usually present with acute severe pain, which usually involves the metatarsophalangeal joints and famously known as the podagra, when it first occurs as the first attack. And this pain usually starts at night. Following the acute attacks, there will be a period called intercritical period, which is usually associated with pain period, free period of pain. The patient might not having pain at this time, but still having elevated urea level, and the more joints will be affected. Attacks occur more frequently and last longer during this period. More joints are progressively affected. Then arthritis tends to ascend and to involve the upper limbs. There will be progressive joint deformity as this disease ensues. Then the last stage is the chronic tophaceous gout. Next slide, please. So the acute gout attack, which index patient presented with, like I've mentioned, is the initial manifestation of gout. Usually it's monoarticular. A maximum inflammation occurs within 12 to 24 hours. The first metatarsophalangeal joint is the most commonly affected joint, and joints with osteoarthritis are at increased risk. The periarticular structures such as the tendons and bursae may be involved as well. Next slide, please. There may be associated prodromal symptoms like fever, malaise, and fatigue. And the initial attacks, usually they resolve spontaneously even without intervention, usually lasting between 3 to 14 days. Over time, the flares of the gout may be more frequent and less intense and involve more joints. About 60% will experience a second attack within a year, and about 80% within the next 3 years. Next slide, please. So this is a picture depicting the involvement of the metatarsophalangeal joint. Usually, if it happens at the first attack of gout, we call it podagra. Next slide, please. Now coming to the precipitants, they include, this is a non-exhaustive list and includes local trauma, alcohol binges, weight changes, diuretic use, initiation of urate lowering drugs, acute myocardial infarction, among others. Next slide, please. The differential diagnosis include calcium pyrophosphate deposit disease, reactive arthritis, cellulitis, gonococcal arthritis, rheumatoid arthritis, psoriatic arthritis, and urate nephropathy. Next slide, please. Now, coming down to investigation, synovial fluid analysis is the investigation of choice, as many other inflammatory conditions might mimic this gouty arthritis, but McCarthy and Hollander in 1961 were able to provide some polarized light, which will be able to visualize these individual crystals to know which one is differentiated from sodium or from calcium crystals. The appearance and the distance will also differ, and usually there will be leukocytosis, usually between 2,000 to 60,000. Gram stain and culture to exclude coexisting septic arthritis is also important. Next slide, please. This is just a picture depicting the spindle-shaped or rod-shaped crystals of monosodium urate in the intracellular department. Next slide, please. So the slide is trying to compare the different types of arthritis. The parameters involved include the normal color, the viscosity, the WBC count, as well as the differential counts. And it's trying to differentiate between non-inflammatory, inflammatory, and septic synovial fluid analysis. Next slide, please. Other auxiliary investigations that one could do include serum uric acid level, full blood count, ESR and CRP, which are acute phase reactants are expected to be elevated, electrolyte urea and creatinine to have a baseline and to rule out urate nephropathy. Lipid profile, liver function tests, and imaging are also important. Chest X-ray usually in the early stages might show just soft tissue swelling, but as the disease advances, it's likely to show more destructive joint changes. You can also do ultrasound, CT, and MRI of the affected joint, which are proven to be more specific and more have more sensitivity. Next slide, please. So the aim of the management is to alleviate inflammation and symptoms in acute flare and to reduce serum urate levels to suppress flare-ups and promote regression of TO5. This is achieved using, next slide, please. Using therapeutic lifestyle modifications like to maintain ideal body weight, drink at least 2 liters of water, moderate exercise, avoid alcoholic binges, avoid dehydration, and avoid soft drink containing sucrose and fructose. Next slide, please. The treatment for acute attack includes non-steroidal anti-inflammatory drugs. I will mention here that based on most of the studies conducted, there is no single anti-inflammatory drug that is said to be more potent than the other, depending on the side effect profile of the patient. And this NSAID should be used in caution in patients with renal impairment, hepatic impairment, patients with congestive cardiac failure, and patients with ulcer disease. Oral prednisolone can also be used. Intra-articular steroids can also be used. We can also use interleukin-1 receptor antagonists like anankira, which have been proven to have a high potency in terms of regression of inflammatory attacks. Next slide, please. The aim of the long-term normalize is to normalize the serum urate, and the goal is to achieve a uric acid level to approximately 6 mg per deciliter in patients without tophi, and 5 mg per deciliter in patients with tophi. Next slide, please. There are indications for initiation of these drugs. These uric acid lowering drugs can be categorized into the following groups: xanthine oxidase inhibitors like allopurinol, febuxostat, uricosurics like probenecid and benzbromarone, uricases like pegloticase, and rasburicase, which has been withdrawn from the market because of the increased risk of immunogenicity and anaphylactic reactions. Other drugs that have been found to have some uricosuric effects include losartan, amlodipine, and fenofibrate. Next slide, please. So this is the criteria for initiating uric acid lowering therapy. Patients that are having frequent or disabling flares of gout greater than 2 episodes per year. Patients with CKD stage 3 and above, TOFOS diagnosis on physical examination, past history of urolithiasis, chronic tophaceous gout, and patients that are also having, are going to have some chemotherapy. Next slide, please. So in conclusion, gout is a rheumatologic disease that is amenable to treatment. The overall disease burden is substantial and is on the increase. Lifestyle modifications that are recommended for gout generally align with those for major chronic disorders. Thank you for listening.
Oh, thank you so much, Dr. Salim, for that beautiful and lucid presentation. It was very detailed. Okay, thank you, Dr. Suri, for sharing the slides. Okay, so now we'll take comments and questions first from the participants. And please, let's keep the thanks coming on the chat. Let's keep the thanks coming.
So,
Dr. Thanks.
Dr. Flores hand is up.
Okay, ma'am. Okay, please, Dr. Flores, please go ahead.
Okay, thank you so much for that extensive presentation. Most of the questions I had, I saw them in your presentation, but I just want to add on. Okay, for this particular patient, this patient actually has a monoarthropathy, that's a monoarticular problem. Okay, so I was thinking like an additional differential should be pseudo gout, of which pseudo gout can be seen in metabolic diseases. A risk factor is metabolic disease and also aging, though the patient's age was not stated here. Then secondly, osteoarthritis. If you notice, this patient was actually obese, so that's also a risk factor for osteoarthritis. So I think like an add-on to the acute flare of gout or gouty arthritis, I think pseudo gout and osteoarthritis can actually come in there as a differential. Okay, then secondly, things that can be other comorbidities that can be associated with gouty arthritis are solid tumors like the leukemias, the lymphomas. Why being? Because they actually break down DNA, and then when you break down DNA, what happens is that it leads to production of uric acid that will increase the production of uric acid in the blood. And then Secondly, we have disease condition like the Leishman syndrome. So what happens in Leishman syndrome is that there's increase in the ribose-phosphate diphosphokinase. So when it is increased, what happens is that the purine nucleotides are also increased, thereby increasing the uric acid. So these are conditions that could also be associated with hyperuricemia because they bring about increased production. Then you've mentioned those other conditions like DM, hypertension, CKD. So what that basically does that it inhibits the excretion of uric acid. So the comorbidities that are associated with gouty arthritis they are grouped into those that increase the production of uric acid and those that reduce the excretion of uric acid. So those that actually increase the production of uric acid are the conditions I mentioned, like the solid tumors and the Leishman syndrome. And those that actually reduce the excretion are what you mentioned, like the CKD, the DM, the hypertension, and all you mentioned. Then, secondly, the crystals that can be seen in gouty arthritis, like an add-on to the needle-shaped negatively birefringent. We also have crystals like the monosodium monohydrate crystals. So those are actually crystals we see in gouty arthritis. Then, most times they try to tell you, okay, how do you differentiate between pseudogout from gouty arthritis? So this is just like an add-on. Okay, so for the pseudogout, you said for the gouty arthritis, we actually have the needle-shaped negatively birefringent. So for the pseudogout, we have the rhomboid-shaped positively birefringent. Then the crystal we see for pseudogout is calcium pyrophosphate crystals. That's basically what we see. Then things that can be associated with pseudogout because they're actually interwoven. So things that can be seen in pseudogout are actually hyperparathyroidism, homochromatosis, hypercalcemia, hypothyroidism. So this is just like an add-on to what you said. So, but generally, you did a great job. The other questions you've actually answered in your presentation. Thank you so much. Thank you.
Thank you, Ma.
Thank you so much. Thank you so much, Dr. Florence. Okay, Dr. Yahaya, please go ahead.
Okay. Thank you, Chief Ekele. Thank you, Dr. Salim. Thank my teachers. I think it's a very good one. Most of what I wanted to say has been said by Dr. Florence. Is actually a very good one. And pseudogout should be one of the differentials, not only during the literature review, looking at the close relationship and close mimic of gout and pseudogout. And basically, all what I have about that has been mentioned by Dr. Florence. So again, to qualify more is monoarticular arthritis. So the differential should be more tilted toward differentials of monoarticular, but like OA, maybe monoarticular osteoarthritis, septic arthritis, even to some extent rheumatoid arthritis. So the pseudogout is very good differentials and is seen in a bit advanced age than patient with gout. And just like what Dr. Florence said, it's usually positive birefringent rhomboidal shape crystal. And sometimes again, X-ray may help because the finding from pseudogout usually they have chondrocalcinosis. Unlike against gout, which you mentioned initially, they may not have X-ray findings, but again, being an erosive disease, subsequently they may have erosion, destructions of the joints. And I think it's worth to bring some of this investigation, not during the literature review, like the question that asks, what are the other investigations that you do? So apart from that, you have to add with the X-ray. Then the drug for the treatment, I think it's only during the literature review that we mentioned immunologic like anankira, that's interleukin-1 and antagonist. So it's also very important in some selected of patients. So I just want to ask one thing. If you have patient with acute flare of, for long-term treatment of gout, somebody with chronic kidney disease, what will be your uric lowering agent of choice? Thank you. Thank you very much.
Thank you, Dr. Yahaya. Dr. Salim, do you want to react to that?
Okay, thank you very much for your comments, contributions, and the question. So just like you've mentioned, depending on the degree of the renal impairment, If it's mild to moderate, you can still use your allopurinol as the first choice. But other than that, if maybe for moderate to severe, you can use newer agents like febuxostat, which have also been found to be effective in the lowering of serum uric acid levels. Thank you.
All right, thank you so much. Thank you so much. Okay, Dr. Maduka.
Okay. Good morning, teachers and colleagues. I want to thank the
Sorry, am I the only one not hearing him?
No, we cannot also hear him. Maybe his network
Okay,
is
Dr.
fluctuating.
Maduka, I think we lost you. I think we lost you. Okay, so while we're waiting for him to come back, let's take some comments on the chat. So a lot of thanks to you, Dr. Salim on the chat, Dr. Adivoka, Dr. Wike, they're all saying thanks. Dr. Brown, Dr. Mustafa, Dr. Justice, Dr. DMO. Dr. Becky says, please, what dose of aspirin increases risk of gouty arthritis? Do you want to react to that?
And thank you very much for the question. For most of the literature reviews that I've come across, they just said low dose aspirin, but I've not seen the exact dosage as to which one qualifies for low dose or which one is high dose to warrant risk of hyperuricemia in an individual. But they just said low dose aspirin as a risk factor in most of the literature reviews that I've come across.
All right, thank
Thank
you.
you.
Okay, Dr. Aminu Bashir saying thank you so much for quite detailed and concise presentation. Dr. Cyril says, thank you very much for the presentation. What do you mean by urocostatic agents? And then I think that's Dr. Kalamama, I want to spell there, has touched the other concerns. You want to react to that?
Okay, for the urocostatic agents, which are the allopurinols and the astaxanthin oxidase inhibitors, what they usually do, they normally stabilize the urate in the blood. And for what is needed for the gout to develop is for this thing to be concentration of the uric acid to be more so that it can precipitate and then gets through the blood so that it can get deposited to different parts of the body like the joints and other soft tissues. So if you have a serum uric acid level of greater than 6.8, the saturation point is said to be reached, and then at this point it can precipitate into the blood and can be distributed to different organs. So this group of drugs, the urocosurics, the xanthine oxidase inhibitors, they tend to prevent this from occurring. Thank you.
Okay, thank you for that reaction. Dr. Adebimpe says, thanks for the excellent presentation. What's the duration of drug treatment in the acute phase, especially with prednisolone use?
Okay, thank you very much for that question. Thank you very much for the question. Am I audible, ma?
I can hear you, go ahead.
Okay, like I've mentioned during the course of the presentation, usually an acute flare of gout is usually self-limited even without treatment. So you tend to give the treatment for about a period of 10 to 14 days, tapering the drugs, either using NSAIDs or prednisolone. Usually you use the prednisolone in doses of 20 to 40 milligrams daily, then you taper it off over the next 2 weeks. Thank you.
All right, thank you. Okay, so Dr. Andrew Godia says, thank you for the presentation and all the other contributions. In pseudogout, what you see is a weakly positive birefringence calcium pyrophosphate crystals. Okay, thank you. And then Dr. Peter says, I came across less than 300 milligram as low dose. I guess that's aspirin. And then Dr. Afyang Basi says, the X-ray reveals deep erosions with overhanging edges, punched erosions. I think that's for gout. Thank you so much, everyone who made a comment. Chief, I don't know whether you mentioned colchicine among the drugs. Okay, we have more hands. We have more hands. Okay, Dr. Maduka, are you back? Can we hear you now?
Yes,
Okay,
I'm back. Sorry, I had some network issues. So I was saying that for the therapy to initiate treatment for gout, acute flare of gout, usually combination therapy that is being advocated now. So you start with an NSAID and colchicine. Typically, steroids, prednisolone is usually not encouraged because some school of thought have problem with it. But you only bring it in if the patient has been having recurring flares for a very long time. So they will now say, okay, you cannot break it in. But ab initio, they usually don't use prednisolone, but they use NSAID and colchicine together, not just NSAID. Thank you.
Wow, thank you so much. Okay, Dr. Lawrence, go ahead.
Thank you.
And then our chief will come in.
All right. Thank you, Dr. Salim, for a wonderful presentation. I just want to respond to a question that Dr. Aya asked you, which I think he didn't respond to it very well. He was asking in the setting of CKD, and the patient has acute flare, what would be your choice of drug? You know, as we have said that there are 3 drugs we can use in acute flare, NSAID, steroid, and colchicine. In the setting of CKD, you want to avoid the NSAID completely. You can combine both colchicine maybe at low dose, maybe like 0.5 milligram, and the steroid. At that particular stage, when there's acute flare, you will not want to start xanthine oxidase inhibitor like allopurinol, except the patient has been on it before. If the patient has not been on it before, you will not want to initiate it because it can worsen the flare because it will allow the deposition of the crystal at the joint at that particular time. But if the patient has not been on any of those xanthine oxidase inhibitor before, you will not want to initiate it at the acute stage. You want to give only steroid and colchicine, but you avoid NSAID as much as you can in a setting of CKD. Thank you.
Wow, thank you so much, Dr. Lawrence, for that.
Ade.
Okay, sir. Sir, please go ahead. Sir, Dr. Shitu.
Oh, good morning. Good morning, Dr. Kelly. Good morning. Good morning, everyone. I think the second to the last speaker addressed one of the things I wanted to talk about, ensuring you take NSAIDs together with the colchicine. Then, yes, the last speaker about CKD, it depends on the stage of CKD. Yes, in stage 3 and above of CKD, or patients with an acute decompensation in form of AKI on top of CKD, you want to avoid NSAIDs altogether. But of course, stage 1, stage 2 CKD, yes, you still go ahead and use your NSAIDs, but of course with caution towards the dose. Then yeah, you can do that. Then for the use of allopurinol or fabricostat in patients with CKD, well, in renal impairment, if GFR is less than 20 and you're on allopurinol, ideally you should reduce the dose. You usually don't want to go beyond 200. And then when the GFR starts going below 10, you don't want to give more than 100 of allopurinol. Also, fabricostat too, you have to adjust the dose. When GFR is less than 30, you can't go more than, I think, 40 or so a day, thereabouts. Okay? So, but you do dosage adjustments. You don't have to stop allopurinol altogether. If it's working for the patient, you just adjust the dose. Fits what you're dealing with. You also have to afford for patients, and the older people that we may meet in the exams may not would prefer for you to say allopurinol rather than saying fabricostat sometimes. Okay, so just do that, but you don't have to stop allopurinol. Okay, in fact, you just have to reduce the dose. Basically, that's it. So you first reduce the dose and then increase the intervals, as the case may be. But the presenter did very well. Yes, one more thing: the low dose aspirin and gout. Yes, it's a risk factor for gout. If long-term low dose aspirin, and that's what studies have shown, because there was evidence to show that patients on long-term low dose aspirin develop that. But For acute use of aspirin, I don't think any of the studies that they used talked about that. Okay, I stand to be corrected, but none of the studies talked about, you giving high dose aspirin for a certain period of time and being linked to gout. And the studies showed that low dose aspirin, long-term low dose aspirin, particularly for prophylaxis against vascular disease and all of that, either as primary prevention or secondary prevention, is what was linked to gout. Okay, so you need to state that it's long-term low dose aspirin. So thank you. Well done, everyone.
Thank you so much, sir. Okay, I think I'll hand over to Margaret Sobel.
Oh, thank you so much. The presenter, all that contributed. Thank you. Chief Chito already coming. Don't know any other facilitator have anything to say before I call Dr. Fatima. Chief Amigos, Chief Cookie, Kopi, Dr. Dahatu, Dr. Success, any comments?
Anyway, thank you so much, Ma. I've been so impressed by the beautiful presentations and interactions of the participants. I think going for this exam, what we are seeing, it will be a lot easier. The talking, the contribution, they've been quite impressive. I've actually seen there have been improvement from one class to the other. Thank you so much. Yeah.
Yes, thank you. You're right, Dr. Kopi. This class, I don't know, maybe because of the class reps, the class is very organized. Dr. Lawrence, Dr. Maduka, I don't know if I got all the names. Thank you for your contributions. Chief Chito, I know, I don't know, thank you for your contributions. Those are questions, thank you. I don't think I got all the names. Dr. Kalamama, as always, thank you for your contributions. Thank you. So let me, Dr. Fatima, hope you are ready for us.
Yes, ma'am.